Yeah, good morning. Good morning to all the family third year students. So this is Dr. Sunil Kumar discussing pharmacology 2. In that, I was discussing diuretics in the last session, and I think I classified diuretics and even explained brief mechanism of action of all the diuretics while classifying the diuretics. So now let's discuss individual diuretics in detail. Okay, let me share the screen. Yeah, I think this screen is visible to you. Just a minute, I would like to maximize it. Okay. So let me tell you, first of all, let me discuss about high ceiling diuretics. High ceiling diuretics are also called as loop diuretics. Okay. High ceiling means the word ceiling means response. High ceiling means they are going to produce a maximum response. Okay. And here, out of all the diuretics, this high ceiling diuretics are the most potent diuretics. Okay, and they are going to produce profuse diuresis. Up to 10 liters of urine can be produced by these diuretics in a day. Okay, and they are also called as loop diuretics. Why? Because their major action is on ascending limb of loop of Henle. They act on ascending limb of loop of Henle, and they are going to inhibit a pump which is known as sodium potassium chloride co-transport system that I will discuss. So by inhibiting that pump, they prevent reabsorption of sodium and water, and thereby they increase the excretion of sodium and water. Okay, and here you can see loop diuretics are very potent and can increase sodium excretion by 20 to 25%. They can increase the sodium excretion by 20 to 25%. And they are used when rapid diuresis is necessary. Okay, so in case of severe hypertension, where hypertension is due to increased blood volume, in those circumstances where rapid diuresis is required, so you can use these diuretics, or you can use in serious poison conditions where the poison has entered into systemic circulation and the poison has to be removed at an earliest. Okay, poison has to be removed from the blood at an earliest. So there you increase the urination and the poison will be eliminated through urine. Okay, by using these diuretics, that is loop or high ceiling diuretics. Or when other diuretics, especially when thiazide diuretics are fail to produce enough response, or when the desired response what we are expecting, if it is not we are not getting with thiazide diuretics, even then you can use loop diuretics. Okay, and here the diuretic response goes on increasing with the dose. Okay, and up to 10 liters of urine may be produced in a day. It depends on the dose. Okay, as you increase the dose, the diuretic response will increase. Okay, and the maximum at a maximum up to 10 liters of urine may be produced in a day. Okay, and the onset of action is very quick and prompt. If you give by intravenous route, so the diuresis will be seen within 2 to 5 minutes. And if you give by intramuscular route, diuresis can be seen within 10 to 20 minutes. 10 to 20 minutes. And if you give by oral route, definitely the diuretic response can be seen within 20 to 40 minutes. Okay, and duration is also very short. Within 3 to 6 hours, the drug gets eliminated from the body. Okay, so that is about high ceiling diuretics. Okay, that is the introduction. Next, coming to mechanism. So here, let me tell you. So just a minute, I would like to change my place. I think there is quite disturbance with this light. Just a minute. Yeah, now it is quite comfortable because you should see my face even. Yeah. So this is the mechanism of action. So mechanism of action of loop diuretics. Okay. So before discussing the mechanism of action, let me tell you how reabsorption occurs in your nephron. Right? So nephron, consider the nephron as a tube, and in that tube many substances will enter, many solutes will enter, and how these ions will be reabsorbed from this nephron. Well, let me show you. For example, if this is your nephron, for example, so if this is your nephron, for example, it's like a tube, and here there are cells like this on either side. On either side, you have cells. Okay, and this empty portion, this empty portion where substances will move, okay, and they are coming out of the urine. So that particular, that coming out of the tube, that is called as lumen. I will write it as L. So this I have shown here, lumen. L means lumen. Okay, and here this particular cell, it is called, I will write it as C. This is C. Okay, here it has been shown, that is epithelial cell of thick segment of ascending limb of loop of Henle. Okay, and this portion I will consider as blood. B is blood. So now generally substances like sodium, for example, if I talk about sodium, sodium will be reabsorbed in this manner. First it will enter into the cell, and from cell it will enter into the blood. Okay, got it? So here, yes, just I will write it as yes. Sodium will be absorbed in this manner. First it has to enter into the cell, then it has to enter into the blood. Okay, so now what is happening, that entire this particular portion, I would like to zoom it, and I would like to show here. So this particular part which I am showing here, it is related to thick ascending segment of loop of Henle, or thick segment of ascending limb of loop of Henle. So this is the site of action of loop diuretics. Okay, and here you can see, so from lumen, how the ions will be absorbed. From lumen, sodium chloride and potassium, it is absorbed by a pump, and this pump or transport system is called as sodium potassium chloride co-transporter. It is called as sodium potassium chloride co-transporter. Okay, and from here, from lumen, it is absorbed in this direction. Okay, first it has to enter into the cell, and this cell is, this particular cell is called as epithelial cell of thick segment of ascending limb of loop of Henle. Okay, and you may ask a question, sir, where it is happening inside the nephron? It is happening here. I am showing you this portion. I am showing you this portion. Okay, in this portion, the absorption is going on in this fashion. And this, you can see here, this blue color, this is the transport system. This is a transport pump. Okay, the same thing I have displayed here. So from lumen, so ions like sodium, chloride, and potassium, they will enter into epithelial cell of thick segment of ascending limb of loop of Henle. From loop of Henle, ions will enter, especially sodium will enter into the blood. I can say that sodium is absorbed in the blood with the help of this sodium pump. This is called as sodium potassium ATPase pump. And remaining ions, potassium and chloride, they are absorbed by a symporter. This is symporter, which is carrying two substances in the same direction. So this is how sodium, potassium, and chloride are reabsorbed in the blood. And the major role of diuretics is to prevent the reabsorption of sodium. Is to prevent the reabsorption of sodium. And here, let me tell you, in this portion, especially in the thick ascending limb of loop of Henle, around 20 to 25% of sodium load is reabsorbed. Please try to understand. 20 to 25% of sodium that is entering into this empty tube. Okay, so here, whatever the sodium that is entering, around 20 to 25% of sodium is reabsorbed, especially in this thick segment of epithelial cell of thick segment of ascending limb of loop of Henle. Okay, now diuretics will do only one thing. These loop diuretics, they will inhibit this transport system. You can see here. So loop diuretics, I have shown you a minus mark. Minus sign indicates inhibition. Okay, and when this is inhibited, so you can expect, you can see sodium, chloride, and potassium will not be reabsorbed. Right, the pump which is responsible for the reabsorption of sodium, potassium, and chloride, which is called as sodium potassium chloride co-transporter or symporter, it will be blocked by loop diuretics. Sodium, potassium, and chloride will not be reabsorbed into the epithelial cell, will not be allowed to enter into the epithelial cell, and further it will not be reabsorbed. So this is the mechanism of action of a loop diuretics. Okay, I hope you got it. Yeah. So it's simple. So there is a pump which is responsible for the absorption of sodium, potassium, and chloride, and around 20 to 25% of sodium is reabsorbed with this pump. Okay, and this pump is blocked by loop diuretics, and the absorption of sodium, chloride, and potassium will be blocked. Okay, and finally, these ions will be eliminated into the urine. So directly they will come into the urine. Thereby, you are increasing the sodium loss by 25%. Got it? So when normally sodium, the amount of sodium that is excreted per load is only 1%. Only 1% is excreted. Remaining 24% will be reabsorbed. But by blocking this transport system, you are increasing the sodium elimination by 25%. Okay, and I told you, as sodium, along with sodium, water will also be eliminated, because both sodium and water are like friends, right? Because both, due to osmotic pressure, wherever the sodium travels, so water will also travel along with sodium. So if you allow the sodium to go out of the nephron, by preventing its reabsorption, automatically water will also be allowed to go out. That's why your loop diuretics will cause extreme elimination of sodium as well as water, both. Okay. Along with that, you can see chloride and potassium also excreted. So this is how loop diuretics will work. And as why they are called as profuse diuretics, the reason is simple. They are increasing the excretion of 25% of the sodium load. Okay, 25% of the filtered sodium will be excreted, and 25% of the filtered load will be prevented to get reabsorbed. Okay, if you compare with thiazides, thiazides will prevent the reabsorption only to 10%, because in distal convoluted tubule here, you can see in distal convoluted tubule only 10% is reabsorbed. Thereby the drugs can block the 10% reabsorption, thiazide diuretics, and they can increase the elimination of 10%. But here in this loop of Henle, 25% of sodium is reabsorbed. Okay, that's why by blocking this sodium potassium chloride co-transporter, so diuretics will increasing the excretion of 25%. 25% of sodium will be excreted out along with water. So that's why we call it as a strong diuretic. We call it as a profuse diuretics. Okay. Yeah. Yeah. So explanation is given here, just to go through. So these drugs act primarily on the thick segment of ascending limb of loop of Henle, inhibiting the transport of sodium chloride out of the tubule. They will not allow the sodium and chloride to get reabsorbed here. So sodium chloride, this is tubule. Okay, so from this empty space, so this is L lumen. From this empty space, so it is not allowed to reabsorb. Sodium chloride reabsorption will be blocked because this pump is blocked. Okay, so by inhibiting the sodium chloride out of the uh, inhibiting the transport of sodium chloride out of the tubule into the blood by inhibiting this pump, that is sodium potassium chloride co-transporter in the luminal membrane. Okay. So luminal membrane means the membrane which is facing towards lumen. Okay. So this membrane, this is facing towards lumen. So that's why this is luminal membrane. So the pump, this co-transport, sodium, potassium, chloride, it is mainly present on the luminal membrane. Means from lumen facing towards lumen. Okay. They are present on the epithelial cell, but this pump is facing towards lumen. Am I right? So that's why the word luminal membrane comes. Okay. So if a pump is facing towards lumen, then we call it as luminal membrane. Yeah. So here you can see the thick ascending limb of loop of Henle has an reabsorptive capacity and is responsible for reabsorption of 25% of filtered load. Whatever the sodium that is filtered, out of that 25% will be reabsorbed here. You can see. So 25% will be taken back. Like arrow mark indicates reabsorption. So here sodium. So 25% is reabsorbed. But you block this pump by loop diuretics, the sodium potassium chloride co-transport system. If it is blocked, definitely the 25% of this one will travel. So they will travel all along the length of the nephron, and finally they will come into urine. Okay. So that is the concept. Got it? Yeah. So here the explanation is given. Loop diuretics block the symporter and prevent the reabsorption of sodium. That is 25% sodium reabsorption will be prevented. In other words, 25% of sodium will be excreted. Okay, is it clear? And as I told you, due to osmotic pressure, water reabsorption is also reduced because water will have a tendency to move along with sodium. That's why water will also be excreted. And if out of 100% load of sodium, if 25% is eliminated, such a large quantity of sodium is eliminated, automatically large quantity of water will also be eliminated. Okay, that's why there is a profuse diuresis. There is a very, very strong diuresis. Up to 10 liters of urine can be produced in a day. It depends on the dose. Okay, so normal loss of sodium is only 1%, but if you use loop diuretics, the loss of sodium will be 25%. Okay, and also increased sodium loss. Increased sodium loss will also increase the loss of hydrogen ion, chloride, and potassium. Okay, yeah, increased sodium loss will also increase the loss of H plus, Cl minus, and K plus. Okay, they will also, because their transport is also blocked. Here you can see. So even potassium is not allowed to reabsorb. So that's why. So potassium will also go out, and that will result in severe hypokalemia. Severe hypokalemia and loss of H plus ion will also result in metabolic alkalosis. Metabolic alkalosis. If acid leaves your body, then your blood pH becomes alkaline. That is called metabolic alkalosis, and that will cause severe electrolyte disturbances, and that can cause even vomiting, that can cause abdominal cramps, and that can even cause make the patient to enter into a coma. Okay, and even chloride will be lost. Large amount of chloride will be lost. Okay, so you can see here. That's what loop diuresis may cause metabolic alkalosis. Okay, and here you can see there is an increased excretion of calcium and magnesium. Okay, you may ask a question, sir, when sodium is lost, okay, potassium will be lost, calcium, chloride will be lost, and due to osmosis, water will be lost, and also H plus ion will be lost. Okay, that's fine. Then what about calcium and magnesium? Okay, how their excretion is increased along with loop diuretics. So I would like to show you a small picture. You can see here. I think this is visible to you. So this is the pump, sodium, potassium, chloride co-transport. And here you can see sodium, potassium, and chloride, they are absorbed. This is lumen, empty tube. They are absorbed from empty tube into this epithelial cell, and from epithelial cell, they are absorbed into blood. They are absorbed into blood. But here, the absorption of sodium, potassium, and chloride, it acts as a primary transport system. Okay, by utilizing this transport system, you please try to understand, by utilizing the electrochemical gradient, by utilizing the energy generated by this transport system, two other ions will also enter into the cell. Two other ions will also be reabsorbed. And what are those ions? Here you can see calcium and magnesium. Got it? Okay, I think you know about this sodium potassium ATPase pump. Innarama eppudaina? Sodium potassium ATPase pump, which will reabsorb sodium. Is it clear? Which will remove sodium actually, which will remove sodium from cardiac cell. Okay, and when it removes sodium from cardiac cell, along, along by utilizing that particular energy, some other ions will also enter. Glucose local kelton cell local. Okay, is it clear? So by utilizing the electrochemical gradient, by utilizing the energy produced by this pump, because you know that so ATP, adenosine triphosphate, has to be converted into ADP. Okay, ADP ka convert avvala. Okay, then only this transport system will work. ADP plus another phosphate. Okay, so then by utilizing this energy, uh, 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 sodium, potassium, and chloride will enter inside. This is the transport system. By this energy, these three will enter. Okay, and by utilizing the energy produced by ATP breakdown, two other substances will also enter into this. That is called as calcium and magnesium, Ca plus 2, as well as Mg Mg plus 2. Okay, yeah. And here the thing is, this pump is work with ATP, with energy. This is an active transport system. Okay, so ATP hydrolysis will generate ADP, and as a result of this, this pump becomes active, and sodium, potassium, and chloride will enter inside. And by utilizing this energy produced by the ATP hydrolysis, two other substances will also enter into the cell, like calcium and magnesium. This is ongoing process. But what is happening here when loop diuretics block this pump? When loop diuretics block this pump, ATP will not be hydrolyzed. The pump remains inactive. When the pump remains inactive, it doesn't undergoes ATP hydrolysis. When ATP is not utilized here, then energy is not produced. When energy is not produced, these two substances will not be entered inside. They will also not enter inside because they require the energy of ATP hydrolysis. So hence, you can see here, there is also an increased excretion of calcium and magnesium. Okay, calcium and magnesium kuda bayitiki vellipotundi along with sodium, potassium, and calcium. Along with sodium, potassium, and calcium, you can see, along with sodium, potassium, and chloride, calcium and magnesium uh, uh, will also go through urine. Will also be excreted by urine. Okay, this is the logic. Got it? And also, there is another thing I would like to say. You can see here, there is a decreased excretion of uric acid. Okay. So, uric acid, okay, sir, calcium and magnesium excretion is increased because it is utilizing the energy produced by the pump through which sodium is reabsorbed. When the pump is blocked, that energy will not be provided, and thereby calcium and magnesium reabsorption is blocked. So they will also go out. Then what is the connection between decreased excretion of uric acid? See, this is called competitive inhibition. Okay, so what is happening here? So this uric acid, it utilizes a pump that is called organic acid transport pump, OAT pump. OAT pump, organic acid transport pump. And but with the help of this pump, uric acid will be excreted, uric acid will be eliminated. Okay, but here what happens? Loop diuretics also utilizes this pump to enter into the site of action. Please try to understand. Loop diuretics will also bind with this pump in order to enter into the site of action. In order to enter into that particular site of action, loop diuretics require this organic acid transport mechanism or pump. Then there is a competition between uric acid. There is a competition between uric acid, which will bind with this pump, and it will try to come out of the kidney. Okay, and simultaneously, loop diuretics, they will also try to utilize this pump. They will also try to utilize this pump to enter into that particular site. That is what we call it as a thick ascending limb of loop of Henle. Then what will happen? Both will have a competition, and finally in that competition, loop diuretics will win and uric acid will fail. Means loop diuretics will prevent uric acid in binding with organic acid transporter. That's why uric acid fails to bind with organic acid transporter. Okay, because of competition between loop diuretics and uric acid to bind with OAT. So loop diuretics will produce block that transport system that is called as sodium potassium chloride co-transporter, and here uric acid, it will try to get excreted. Okay, so by this with this competition, loop diuretics, by preventing the uric acid to bind with this organic acid transporter, so it will not allow the uric acid to go out of the kidney. Thereby, there is an decreased excretion of uric acid. Uric acid excretion will be reduced, and as a result, you know that when uric acid gets accumulated uh, uh, in your blood, so that uric acid will be converted into crystals combined with sodium, and it will form sodium urate, and that will deposit in your joints, and that will cause severe joint pain, and that condition is called as gout. Gout. Okay, so that is because of hyperuricemia. So that is because of hyperuricemia. Okay, and coming to other aspects, toracimide causes less loss of potassium and sodium. So it is having a mild action when compared to furosemide. And also loop diuretics appear to have venodilator action. This is a wonderful benefit. So it will dilate the veins, and that's why it is going to reduce preload. It is going, see, in congestive heart failure, the heart excess accumulation of blood will occur in the ventricles, and that ventricular volume increases. As a result of ventricular increase in ventricular volume, heart size will increase, and when heart size will increase, myocardial cells will stretch, and they become enlarged, and they will demand more oxygen. Okay, and already oxygen supply will be very less. Okay, so that's why the enlarged ventricle has to be brought to normal. Am I right? That's why you have to remove that excess accumulated blood. Okay, that can be done by dilating the veins. Okay, by dilating the veins, that preload, that the volume of blood that is accumulated in the ventricles at the end of the diastole, that is called as preload. Okay, that preload can be minimized by diverting the blood in the periphery. Okay, the accumulated blood in the ventricle will be diverted to the periphery, and thereby you can decrease preload. You can decrease preload. Okay, that is EDV, end diastolic volume, and thereby you can decrease the size of the heart. Heart size will decrease, and that will provide a wonderful benefit in what? In congestive heart failure. Okay, and after IV administration to patient with acute heart failure, yeah, that's what I'm saying. A therapeutically useful vascular benefit is seen. Vascular benefit is seen. Okay, if the heart size is normal, with a single contraction, it can efficiently pump the blood. But if the heart size is very abnormally enlarged, then it fails to contract. That is what happening in congestive heart failure. Okay, so by reducing the blood, by diverting the blood from ventricles to the veins, it is very helpful in reducing preload and in reducing ventricular size of the heart. Okay, yeah. Yeah. Okay. So remaining pharmacokinetics and all, we will discuss in the next coming class. Okay. So you please go through this video, and any doubt comes to your mind regarding mechanism and all, please raise your doubt. So I will be here to answer. Okay. Thank you.